This is Outbreak News This Week, brought to you by the Global Dispatch Incorporated. Outbreak News This Week is your source for all the news about worms and germs. And now, your host, microbiologist and editor of OutbreakNewsToday.com. Here's Robert Harriman.
Well, hey everybody, this is Robert and welcome to this week's show. And today we're back on topic, worms and germs. Now, a little over a month ago, I did a podcast with today's guest on various infectious disease topics from her book, Gumps ID Pearls, ID being infectious disease. And because it was so well received and the fact that we really just scratched the surface of this interesting topic, I had to have her on for another round of questions. So joining me once again to discuss random infectious disease topics is Associate Professor of Infectious Disease and International Medicine at the University of South Florida Health, Sandra Gompf, MD. Dr. Gompf, welcome back to the show, ma'am.
Hi, thanks for having me.
You bet. Well, let's go ahead and start our discussion on antibiotics and the antibiotic linezolid, or Zyvox, as its brand name is called. Now, it's a pretty relatively new antibiotic, maybe a couple decades old now. What's its mode of action? And as an infectious disease physician, what do you use it for?
Yes, linezolid is relatively new in the class of antibiotics used for treating gram-positive infections. And it is the first antibiotic of the class oxazolidinones. The trade name is Zyvox. There's another oxazolidinone, tedezolid, also known as Civextra, which is similar. It's once daily as opposed to twice daily. The nice thing about linezolid and tedezolid is that they're 100% bioavailable, meaning the oral form gets you the same drug levels as the intravenous forms, just about. The way that these drugs work is they bind the 50S subunit of the ribosome in the bacteria, which makes them protein synthesis inhibitors. They inhibit important proteins in the bacterial metabolism, so it keeps them from growing. And that makes them bacteriostatic. They stop growth for most gram-positive cocci, including MRSA and VRE. And they're indicated for MRSA and VRE. That's methicillin-resistant Staph aureus and vancomycin-resistant Enterococcus. That's their primary use. They are bactericidal against some pneumococcus strains, which is nice, makes it a good choice for community-acquired pneumonia when you suspect penicillin-resistant pneumococcus, or MRSA in particular. It gets great drug levels. Mostly throughout the world, it's actually used for multi-drug-resistant tuberculosis a fair amount. It's one of the few remaining treatments for the extremely resistant TB. So there's a lot of experience worldwide. One thing that has been an interest recently is that it's got excellent bone penetration. So some orthopedists like to use it for bone infections. The only issue is that you need to watch for the adverse effects, because the prolonged treatment can be associated with side effects.
Yeah, and can you talk about some of these side effects?
Yeah. Well, all antibiotics, and linezolid is no different. It can cause changes in taste, can cause diarrhea, and sometimes nausea. The ones that infectious disease specialists are most concerned about, since we tend to use it for longer periods, is if it's taken longer than 7 days, you need to monitor for low platelet count. Sometimes with extended use, it can cause anemia or low white blood cell count. So we monitor complete blood counts when we're giving linezolid for longer periods. One of the more serious but fortunately very rare side effects is mitochondrial toxicity with extended use, since they bind to the monoamine oxidase enzymes on mitochondria. And we tend to see that more with extended use, like year-long use or longer with tuberculosis therapy. Mm-hmm. And that can manifest as fatigue and nerve damage, including ocular nerve damage. So, and unfortunately, most of the ocular nerve findings are reversible, and there can be some peripheral neuropathy, and those are not always reversible. So extended use is a little bit more of a concern and needs closer monitoring.
Yeah. And which class of medications should be monitored closely while you're using linezolid, and why?
Yes. The drugs that should be used with very selectively and with caution with linezolid are the selective serotonin reuptake inhibitors, the SSRIs. And those are most often used for depression and anxiety, a few other conditions. But linezolid mildly inhibits, again, the monoamine oxidase enzyme, and that is an enzyme that helps break down serotonin among a few other neurotransmitters. So if you give linezolid with drugs that increase serotonin, it can cause something called serotonin syndrome, which is primarily manifested by extreme hypertension. Fortunately, again, it's a mild inhibitor, and it's not very common, so you can usually monitor patients for increase in their blood pressure, and the effect is generally reversible within a few days of stopping therapy. It's most likely to occur in the first 30 days or so. So as long as patients are monitored as far as blood pressure is concerned, they should generally do okay.
Good. Well, let's go ahead and totally switch gears. And I would say that the bulk of human infectious diseases are considered zoonoses. That is, there's an animal host somewhere in the link there. However, there is a list of pathogens in which humans are the only existing reservoir outside of the laboratory. Dr. Gompf, what are these pathogens?
Yeah, we don't often think about that, but the commoner ones are among the vaccine-preventable diseases, which is why vaccines are so important for preventing them. And those include measles, mumps, chickenpox, and polio, among the commonest. There are also some of the sexually transmitted diseases like gonorrhea, syphilis, herpes simplex, and HIV are human reservoir only. And a big one worldwide is malaria. So
now, as an ID doctor, when you're thinking about waterborne infections, what pathogens are you considering?
Yeah, there's a number of pathogens, and it depends on the type of exposure, the type of water. You can break it down between saltwater and freshwater, and the one that we see the most in saltwater or brackish water mostly is Vibrio vulnificus, Vibrio cholera, and Vibrio cholera. The freshwater pathogens, when involving skin and soft tissue, we often suspect Pseudomonas and Eromonas. When we see skin and soft tissues with some exposure to farmed fish, for example, tilapia and trout, we think of Streptococcus iniae, which has been reported in the MMWR in recent years. Freshwater exposure and the symptom of diarrhea, we think of Yersinia species, we think of Cryptosporidium in particular. Norovirus tends to be more person to person, but definitely can be transmitted in water. Other skin soft tissue infections, especially in Florida, are Mycobacterium marinum that can cause chronic soft tissue infections. The other atypical mycobacteria, like Mycobacterium avium and abscessus, can cause chronic lung infections, and we see quite a few of those also in Central Florida. One that your listeners may be familiar with related to institutional air conditioning systems and water related to cooling towers is Legionella. Mm-hmm. And as you know, it causes pneumonia, often in outbreak situations. For the traveler or people who are visiting the subtropics or tropics, we've had a few cases here associated with triathlons, people swimming in the Hillsborough River, cases in Hawaii. That would be leptospirosis, which can mimic dengue. And then the ones that we see less often but are high-consequence infections are the free-living amoeba. And the most serious one is Naegleria fowleri, which causes primary amoebic meningitis. And the other amoeba which cause a more chronic or indolent infection are Balamuthia, Mandrillaris, and acanthamoeba, right. Which acanthamoeba also causes contact lens-associated infections.
Right.
So those are the main ones that we run down the list when we're putting together a differential with freshwater exposure.
Sure, and some of these pathogens actually show resistance or some tolerance to chlorine, and we hear about this from crypto and swimming pools and stuff like that.
Yes, definitely. And CDC has stepped up their advertising and awareness regarding cryptosporidium and norovirus in that respect, because it has been associated, they both have been associated with outbreaks related to water and lakes and pools. The other organisms that tend to be more resistant and associated with plumbing or hot water heaters are Legionella and atypical mycobacterium. Atypical mycobacterium has been isolated from shower heads. And in fact, the free-living amoeba, it's not unusual for a lot of harmless amoeba to colonize plumbing, but Naegleria has been associated with primary amoebic meningoencephalitis due to neti pot use or sinus rinsing. So that's something that people need to be aware of.
Okay. Now, South Africa just came out of a pretty large Listeria outbreak, sickened about 1,000 and killed more than 200. Pretty big outbreak. Dr. Gompf, what is Listeria monocytogenes? Who's most at risk? What's its pathology? And what are the common sources of this bacterium?
So Listeria is a gram-positive bacillus that is very hardy, and it's very common in many environments. And it can live in the cold, it can live in heat, it can live in very salty foods like deli meats, even in almost pure salt, and wet or dry conditions. So it is common in a lot of, in the U.S., a lot of food preparation areas, even with excellent sanitation. It has caused outbreaks related to fresh produce and dairy products, most especially in recent years, and from unpasteurized soft cheeses like Hispanic style or Latino style queso fresco. The people who are really most at risk are pregnant women and people with weakened immunity, whether that's from an illness that's causing poor immunity or medication or severe malnutrition. The risk for pregnant women is really to the fetus. It can cause fetal infection called granulomatosis infantiseptica, which, as it sounds, is a disseminated granulomatous infection with sepsis. And it primarily affects the fetus. And mothers may not have very many symptoms when they get sick, and the baby may still have may be born with sepsis or meningitis, or she may suffer fetal loss earlier in pregnancy. The types of foods that are safer for pregnant women and people with weakened immunity to eat are the hard cheeses, if they're made with pasteurized milk or if they're aged for 60 days or longer. And that's an FDA rule here. Soft cheeses, sometimes they can squeeze by saying that they've been aged more than 60 days, but they're really not made safer by aging if they're made with unpasteurized milk. For example, in France, they don't even allow sales of soft unpasteurized cheeses beyond 60 days. And any soft cheese, because of the possibility of environmental contamination, can be contaminated even if it's made with pasteurized milk. So people at risk should really avoid soft cheeses and cold cuts as well, deli meats, that sort of thing.
Sure. How is Listeria treated?
So Listeria is treated for people with who are at high risk and maybe have more serious infection with IV ampicillin and gentamicin, generally for 14 to 21 days. For mild disease, ampicillin may be used orally or even for trimethoprim sulfamethoxazole, but generally treatment for more severe infection would include gentamicin for a more extended course.
Gotcha. Now, one of the things that you do in the Gumps ID Pearls is sometimes you present these short case studies or cases, in which I really enjoy. And one such one concerns treatment with vancomycin, and you write, your patient has endocarditis with methicillin-resistant Staph aureus, or MRSA. He is persistently bacteremic and or febrile after 3 days IV vancomycin. What could be causing his failure to improve? What's the answer to that?
Right. So, if you have a patient with who you know has endocarditis, you've removed all other foci like catheters, and they're persistently febrile or bacteremic, then you have to be concerned that there might be some resistance developing, or there might be some hidden resistance. If you're using vancomycin is a wonderful antibiotic. It's served us for over 2 decades, and there really hasn't been that much resistance at all, almost, with respect to Staph aureus in all that time. However, there is emerging resistance, and there is some evidence that serious MRSA infections may not respond to treatment as expected when the MIC is at the higher end of the susceptible range of 2 micrograms per ml or higher. Some MRSA infections may have small populations with early vancomycin resistance where the MIC is a little higher, such as the VISA, the vancomycin intermediate Staph aureus, which the MIC ranges 4 to 8. That overall population may not register as high enough MIC for the lab to call the whole population resistant. That's called heteroresistance, when you might have a small population. Mm-hmm. Those VISA strains might break through and be causing treatment failure. Or that may tip you off that your patient has infective endocarditis if you weren't aware of that to begin with. The optimal anti-staphylococcal activity of vancomycin requires an area under the curve over MIC of at least 400 for Staph aureus pneumonia and bloodstream infections and endocarditis. And with an MIC of 2 or greater, that concentration may not be achievable safely in the body. So that might be a situation where we might need to consider switching from vancomycin to daptomycin, for example.
So what is vancomycin creep? That's a term I've never heard before, and when should you suspect it?
Yeah, vancomycin creep has been in the literature for a few years, and it refers to the same thing, that small gradual increase in automated culture system MICs to vancomycin and Staph aureus. And you would suspect vancomycin creep when you see an MRSA with an MIC to vancomycin of 2 or greater. Some would say 1.5 or greater. You'd also suspect that in someone with persistent bacteremia or fever or other signs of delayed control of infection. For example, you should suspect an infective endocarditis, again, if you weren't aware of that. And for these patients that vancomycin creep, manual epsilometer testing or e-testing by the microlab may be more sensitive at picking that up. So if you have a patient with that level of MIC and you're concerned that they are not clinically responding, you can ask the microlab to perform that testing for you.
Right. Now, of course, vancomycin is typically used to treat different gram-positive infections. However, some gram-positive pathogens are intrinsically resistant to vancomycin. Which ones are these, Dr. Gompf?
Yes, and when we're thinking of that, remember the Enterococcus gallinarum, Enterococcus cassellaflavus, and Enterococcus flavescens have intrinsic low-level resistance. They're not really common pathogens, and they don't share their resistance genes, so the microlabs will not call them VRE. So sometimes we get calls about that, just so for your listeners' benefit. They are intrinsically resistant, and it's not very high resistance either. But the ones that we want to keep in the back of our heads because they may pop up in patients who are being treated with vancomycin, especially often in patients who are being treated for leukemias or are neutropenic. They have lines. Things like leuconostoc and lactobacillus, the 2 L's, are intrinsically resistant. And then there's Petechiae and erysipelathrix. Leuconostoc and lactobacillus have an association with catheter-related infections and people with hematologic malignancy. So those we try to remember those.
All right. We'll continue our interview with Dr. Gompf on the other side. And the website, of course, is outbreaknewstoday.com. Now, let's follow up on our continuing coverage on the monkeypox cases reported in England. And if you may recall, earlier this month, a couple weeks ago, there was 2 confirmed cases that were reported in just a few days' time, totally unrelated, and both were travelers from Nigeria. Well, this week we learned that a 3rd case has been confirmed in England, and this time it involves a healthcare worker who was taking care of the patient that was at one of the hospitals in England prior to monkeypox being diagnosed. Now, Dr. Nick Finn, he's with the Public Health England. He said this healthcare worker cared for the patient before a diagnosis of monkeypox was made. We've been actively monitoring contacts for 21 days after exposure to detect anyone presenting with an illness so that they can be assessed quickly. It's therefore not wholly unexpected that a case has been identified. Now, this is before they knew it was monkeypox. Since then, English health officials did respond by engaging the biotech company Bavarian Nordic to get a supply of Mvanex. It's a smallpox vaccine, which is approved in Europe. Now, the vaccine is now being used to vaccinate healthcare workers who have been treating patients that were involved with the monkeypox and taking care of them. The Mvanex is not approved for monkeypox. However, it has been shown in the past that smallpox vaccines that were routinely administered were shown to be pretty efficacious in preventing monkeypox, a related virus. Okay, we're up against a hard break. Again, I want to encourage you to check out the website, outbreaknewstoday.com, outbreaknewstoday.com. Also, check us out on Facebook at Infectious Disease News, Twitter at BactyMan63. And after the break, more with Dr. Gompf.
Welcome back to Outbreak News This Week, your source for all the news about worms and germs. Here's your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, welcome back to the program. And let's go ahead and jump right back into our discussion of infectious disease pearls with Dr. Sandra Gompf. Which roundworm, Dr. Gompf, causes periorbital edema and myalgias?
Yes. There are a few things that cause periorbital edema, but very typical, causing extensive myalgias and periorbital edema, especially bilateral periorbital edema, is trichinosis, and that's Trichinella spiralis. And that is a roundworm that is ingested in raw or undercooked meat. So as long as people cook their meat to at least 160 degrees Fahrenheit, they should be fine. Classically, pork tends to be associated with trichinosis. However, we have much better animal raising practices, and the pork industry is very aware, and people are very aware to cook their pork properly. So related to pork is very rare. However, in recent years, people are increasingly interested in different types of foods, especially wild game jerky and home prepared jerky. And those are the situations where we tend to see more of the outbreaks. People who have eaten the same wild game jerky, cougar jerky, for example, has been associated with walrus jerky, and most recently bears. Mm-hmm. Bears in the U.S. almost 100% have Trichinella. So hunters are advised to be very careful with preparing bear meat and cougar meat, that sort of thing.
Right.
The way that you would know that you would suspect that you have symptoms that you might have trichinosis is initially people have the gastrointestinal symptoms like diarrhea, but after a few weeks they develop muscle pains as the worms insist in the muscles. They can develop fever, and that's where you'll see that periorbital swelling and pain in the periorbital muscles. They can even develop a cough, which is usually related to Loeffler syndrome, as the larvae actually pass through the lungs on their way to distant organs. And most of these individuals will have eosinophilia and high CPK.
Sure. Okay, Petechiae. We hear about this in a variety of different infectious diseases.
Yep.
Dr. Gompf, what are Petechiae, and what does that mean to you as an ID doc?
Yes, Petechiae are small, very tiny hemorrhages in the skin, and they manifest as tiny red dots on the skin that do not blanch with pressure. And one test that you can do quickly is to press an empty glass against the skin, and those little Petechiae will not blanch. They'll be much easier to see. You can differentiate Petechiae from a rash of another kind by doing that. And anytime we see petechia and fever, that is bad news to us. So we think, and especially kids and young adults, we think of meningococcemia. If you're in the Carolinas, and there might be some tick exposure, or even travelers from other areas where there might be tick exposure, we think of Rocky Mountain spotted fever. You certainly don't want to wait for the petechia or the rash to appear with that. You just go ahead and treat. But petechia are not a good sign. For people who have a headache, we think of meningitis, again, meningococcus or even pneumococcus, especially in people who don't have a spleen. They're at high risk. And petechia may be an early indicator. We were talking about trypanosomiasis, and certainly people with that can develop petechia. That might be a tip-off. And malaria can cause petechia as well. We can certainly see petechia related to acute infective endocarditis, which is usually due to Staph aureus, and it can be fulminant and cause petechia that way. Those are the main ones.
Yeah.
They're most concerning.
Serious stuff. What is osteomyelitis?
Yes, osteomyelitis is infection of the bones. So any long bone or joint may be involved with osteomyelitis, and there are three basic types. There is the hematogenous form, in which the bone becomes infected from the bloodstream, and that's usually caused by Staphylococcus aureus. It's probably the easiest type to cure, and mostly we'll see that in kids and young adults. The ones that we see most often in older adults are contiguous osteomyelitis and neurovascular osteomyelitis. Contiguous osteomyelitis is related to trauma, basically bacteria driven into the bone by trauma, an open fracture, that sort of thing. And that's harder to cure, about a 50% cure with debridement. Usually there will be gram-negatives and staphylococcus involved as well. And the neurovascular form is, you can consider it contiguous. It's often related to peripheral neuropathy, where people can't feel their feet and they develop an ulcer, and that ulcer, because they can't feel it, gets down into bone. And that is even more difficult to cure. That really depends on the ability to get blood flow down there and clear up the infection with debridement.
What are some of the complications you deal with osteomyelitis?
The main one is non-union of a fracture, like an open fracture, or even, and that can be with hematogenous osteomyelitis. Also, post-trauma, if there's a fracture that there was an open trauma where somebody needed to have pinning or an intramedullary rod, or something of that nature, there might, if it is not, if there's enough infection in there, there may be non-union. Limbs may be shortened, of course, because of that. Patients may have gait disturbances. Some of the things that are less common but more associated with long-term untreated osteomyelitis, and we do see a lot of patients, for example, with shrapnel injuries or old osteomyelitis. They've had it for 20 years, 30 years, and occasionally it drains. Those patients can be at risk for squamous cell cancer in the sinus tract, if they have a sinus tract. They can also develop amyloidosis related to that chronic inflammation. So that's something to think about in those patients.
Well, in addition to the different laboratory studies that you would run, some imaging studies are probably quite useful for diagnosing osteomyelitis.
Yes. The most useful ones, the ones with the highest positive and negative predictive values, are MRI and CTs without contrast. So you'll see those ordered most often. The positive predictive value of bone scans and indium scans is a lot lower, less than 70%, so it's not necessarily useful on its own. You might use it in combination with the other imaging studies. Plain films, you might see 50-50 make the diagnosis on 50%, but you won't see findings on that until about 2 weeks at least of infection. Gallium scans, not necessarily all that useful. So the more useful ones are MRI scans and CT without contrast if you're going to order anything.
Yeah. Dr. Gompf, what is torch syndrome?
Yes, we learned about torch syndrome in medical school, and there's a mnemonic torch, and it refers to clinically very similar congenital infections that are manifested in newborns by a skin rash with petechiae, purpura, jaundice, and it's often referred to as a blueberry muffin rash because that is what it looks like. And torch stands for TO, toxoplasmosis, R is rubella, C is cytomegalovirus or CMV, and the H is herpes simplex 1 or 2. The risk of any of these conditions in the baby is greatest if the maternal infection was acquired in the first trimester.
So what do you do if a pregnant woman has a history of genital herpes? What does the physician do for that case?
Yeah. Well, it's recommended that C-section be performed if there are active lesions or there's a prodrome, if the mother's having symptoms typical of her herpes outbreaks at the time of delivery. And obstetricians will try to avoid procedures that may break the baby's skin, like using scalp monitors, that sort of thing. So because mothers can shed herpes without active lesions, if she has a history of genital herpes, then and the baby's delivered vaginally, they'll check for any scalp ulcers or oral ulcers, skin ulcers. They'll also do surveillance cultures of the vagina and or the baby's mouth at the time of delivery and 48 hours later. And if any of those are positive, then the baby will be treated with acyclovir for 21 days. If mom is diagnosed with symptomatic herpes during her pregnancy, then suppressive acyclovir can also be considered. That may be helpful as well.
And genital herpes in general is very, very serious risk to a newborn.
Very, very serious, yeah. Especially neonatal disseminated herpes, which fortunately is not very common. However, when it happens, it can be fatal in 60% or higher. The mortality of neonatal herpes, if there's only skin or mouth involvement, is extremely low, which is good. The risk of herpes transmission during delivery is about 2% in babies who are born to mothers with active vaginal lesions related to recurrent herpes. So it's low there, but it's much higher if the infection, if the mom has newly acquired herpes infection that's with active lesions at the time of delivery. It's more like 50% or higher.
Now, toxic shock syndrome, that made a lot of headlines back in like 1979 and 1980. But we still see cases of it. I'm sure you do. What organisms are known to cause toxic shock syndrome?
Yeah, so the two major causes of toxic shock syndrome are Staphylococcus aureus, and that's related to an endotoxin called TTS1, toxic shock protein 1, and Group A Streptococcus, which is an exotoxin. That's Streptococcus pyrogenic exotoxin A. So those are the two major causes.
And how can you differentiate the two?
Well, staph toxic shock syndrome is characterized by shock and a diffuse erythematous rash. It can be similar to a sunburn. And staph toxic shock syndrome has been associated with wounds, especially post-operative wounds, even if they do not look as though they're infected. So look under all bandages. It's been associated with highly absorbent vaginal tampons, which that was in those 1970s cases. Might have been related to high magnesium levels in that packing, but still may be associated with highly absorbent tampons now. And then one that our ear, nose, and throat specialists are well aware of is associated with nasal packing or nasal tampons for excessive nose bleeding. lot of our ENT colleagues will give prophylactic antibiotics, and that's not unreasonable because both blood is perfect culture medium for Staph aureus, and Staph aureus usually colonizes the anterior nostrils, the anterior nares, so definitely a significant risk. And then strep toxic shock syndrome is usually related to a deep soft tissue infection, often necrotizing fasciitis.
Let me ask you a couple of questions about rabies that you've discussed in your book. And you write the following, that the following people should have rabies pre-exposure prophylaxis, PEP. And this includes veterinary and animal care professionals, spelunkers, lab workers, and travelers that are going to, rabies endemic areas. Why spelunkers?
Yeah, interesting question. Spelunkers or cavers, people who like to hike in caves, are often exposed to bat colonies when they're in caves. And there is definitely a risk of rabies from either small bites that may go unnoticed if there are a lot of bats, or from high volume of aerosolized saliva. That's not something that we see very typically, but there are and have been cases of reported in the MMWR, for example, of a bat found in a room with a sleeping person, and the person developed rabies. So that could it have been an unnoticed bite? Could it have been aerosolized saliva? There actually have been 4 cases in the United States since the 1950s that were attributable to highly concentrated rabies virus in aerosols. And those 2 of those occurred in laboratory workers working with rabies, and 2 occurred in spelunkers. So spelunkers are considered to be at risk for rabies.
Interesting. Now, of course, all mammals have the potential to have rabies, but in your book you talk about certain animal bites pose a very low risk for rabies. What are they?
Yes. So, you're right. No mammalian animal bite is risk-free. Reptiles, fortunately, do not transmit rabies. Squirrels, interestingly enough, we get a lot of questions, and squirrels aren't often associated with rabies transmission, so they're not really considered high risk. Of the animals that are high risk are wild bats, raccoons, skunks, and foxes. Of course, unvaccinated cats and dogs tend to be the greater risk of exposure in the U.S. But opossums, interestingly enough, are relatively immune to rabies. They have a body temperature about 96 to 97 degrees Fahrenheit, and it's too low for the virus to replicate. So they are relatively resistant to it.
Very interesting. Okay, Dr. Gompf, let's go ahead and close out with this question. And this summer we saw some cases of the relatively rare bacterial infection, capnocytophagia. They were due to dog bites or dog licks, depending on what source you read. Now, not having a spleen is a huge risk factor for this and other infections, as you've mentioned previously in the interview. Can you explain to the audience why not having a spleen is significant?
Yes, so the spleen's major function is to clear out foreign infections, foreign invaders from the bloodstream. So it sort of has a filter function. It has cells that trap bacteria as the blood is flowing through the spleen. So not having a spleen puts people at high risk of especially encapsulated bacteria. Capnocytophagia is one of those encapsulated bacteria. The biggest one is pneumococcus, Streptococcus pneumoniae, and it causes probably about half of the severe infections in people who don't have a spleen. So we make sure that those individuals are vaccinated against pneumococcus. Other things that people without a spleen can get include Pasteurella, Multocida, which you can get from cat bites especially, but also dogs. You can get Babesia, especially up in the northeast area, related to tick bites. There are other encapsulated bacteria like Salmonella, which those individuals can be at risk for, Pseudomonas as well. But yeah, Pneumococcus, Babesia, Capnocytophagia, Pastorella, those are the big ones.
Okay, well, if anybody is interested in checking out her book, Gumps ID Pearls, I'll put a link to that on the website. It's nice, interesting tidbits for those that are interested in infectious diseases. And I want to thank you, Dr. Sandra Gompf, for your being so generous with your time and your expertise, ma'am. Thank you so much.
Absolutely, anytime. I'm very happy to share whatever knowledge I can.
I appreciate it. Thank you, ma'am. All right. Well, I hope you enjoyed that informative interview with Dr. Gompf as much as I did. As a matter of fact, my conversation with her was quite a bit longer, and I was able to produce some podcasts on some of the topics too. So I encourage you to check those out at Outbreak News Interviews on Apple Podcasts, Stitcher Radio, and Spotify. Now, congenital syphilis is a topic we've looked at on the program several times in the past. It's preventable, and it results from untreated syphilis during pregnancy. Now, the consequences for the infected baby is devastating. We're talking stillbirth, neonatal death, blindness, deafness, deformities in the skeleton. Fetal transmission can occur anytime during any trimester. Well, the CDC reported some very disheartening numbers this week. They say that reported cases jumped from 362 in 2013 to 918 cases last year. This is a near tripling in cases, and it's the highest number of recorded congenital syphilis cases in 20 years. Now, cases were reported in 37 states, mostly in the West and in the South. Now, these numbers really reinforce the need for all pregnant women to receive early prenatal care. That includes syphilis testing at their first visit and follow-up testing for women at high risk of infection. Now, syphilis during pregnancy is really easily cured with the right antibiotics. Now, however, if it's left untreated, a pregnant woman with syphilis has up to an 80% chance of passing that on to her baby. Recent CDC research shows that 1 in 3 women who gave birth to a baby with syphilis in 2016 did, in fact, get tested during pregnancy. However, they either acquired syphilis after that test or did not get treated in time to cure the infection in the unborn baby to prevent the adverse health outcomes. Now, CDC recommends that all pregnant women be tested for syphilis the first time they see a doctor about their pregnancy. But for many women, one test for syphilis may not be enough. Women at high risk for syphilis or who live in high prevalence areas should be tested not only at the first prenatal visit, but again, early in the third trimester and at delivery. If sexually active individuals can lower their risk of getting syphilis by being in a long-term mutually monogamous relationship with a partner who has been tested for syphilis and uses condoms the right way each time they have sex. Well, where are we seeing these problems? Louisiana reported the highest incidence of congenital syphilis in the country. 59 cases last year in 2017 at a rate of 93 per 100,000 live births. Wondering about Florida? 93 cases last year at 41 per 100,000 births. So the Sunshine State was one of 5 that accounted for 70% of all cases in the country last year. The other states are Louisiana, of course, Texas, Arizona, and California. All right, time to wrap it up, and I will see you next week on Outbreak News This Week. Good night, and God bless.
Thank you for listening to Outbreak News This Week with Robert Harriman. If you missed any part of today's program, you can listen to the podcast anytime on our website, outbreaknewstoday.com. Make sure to join us here next week for Outbreak News This Week with Robert Harriman.